Good evening. My name is Karen. I'm a Community Education Coordinator for Boulder Community Health. Thank you for joining us for tonight's lecture, Advances in Treating Foot Pain. I'd like to go over the format for the lecture. The lecture portion will last about an hour tonight. Afterwards, we'll use the remaining time for questions. Please type your short general question in the chat box below the video on your screen, and we will take as many as we can. On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Aditya Yerrapragada. Dr. Yerrapragada is a fellowship-trained orthopedic foot and ankle surgeon. Having completed extensive training in foot and ankle surgery, he is highly skilled in treating a broad range of conditions on the foot, ankle, and lower leg. He uses the most modern methods of treatment and minimally invasive surgery. He sees patients at Boulder Center for Orthopedics and Spine in both Boulder and Broomfield. Also joining us this evening are doctors of physical therapy with Boulder Center for Orthopedics and Spine, Chelsea Alexander and Megan Doyle. Welcome to tonight's speakers.
Thank you, Karen. My name is Aditya Yerrapragada, and I'll be talking to you all today about advances in treating foot pain, diagnosis, treatment, and prevention. So a little bit about myself. I originally went to school at the University of Texas in Austin, medical school in Kentucky. I did my orthopedic surgery residency at the University of Washington in Seattle, and did an extra year of surgical training, specifically in foot and ankle surgery in Baltimore, Maryland. I treat all sorts of lower extremity conditions, from the knee, the foot, the ankle, ranging from Achilles tendon surgery, ankle arthroscopy, bunions, hammer toes, flat feet, ankle replacements, and different type of arthritic conditions. A little bit about myself. When I'm not in the operating room, I try to be outside as I can be, just like most Coloradans here. And these are pictures of my family, my wife, our two sons, and so the overview of the talk today, I'll do a brief overview of the general anatomy of the foot and the ankle. I'll go over some relatively common foot and ankle conditions that I see pretty commonly in practice. I'll start with non-surgical treatments and general non-surgical recommendations for these conditions. I'll then go over some operative treatments for when non-surgical treatment doesn't always work. And then I'll turn it over to my colleagues, Chelsea and Megan, who will go over preventative and specific physical therapy regimens for these types of conditions. So the anatomy of the foot and the ankle, there's at least 30 bones, and I say at least because some of us are born with extra bones. And these 30 bones articulate at over 33 different joints and articulations. These are all connected with over 100 muscles, tendons, ligaments, and soft tissue connections. So to say the least, it's a pretty complex compilation of different structures that work together to let us ambulate. Some of the common conditions I see, plantar fasciitis. I'm sure a lot of you watching at home have struggled and dealt with plantar fasciitis at some time. But what the plantar fascia is a thick band of tissue supporting the arch of the foot. Repetitive overuse can cause micro tears, resulting in inflammation, and it's a very, very common condition. Pain is usually in the plantar heel, or the bottom of your heel. A common misconception is that it's in the middle of the arch, which it can be, but more commonly it's in the bottom of your heel. Pain is often worse in the morning or after prolonged sitting, but paradoxically, it can often get worse with prolonged ambulation as well. Risk factors that can contribute to development of this: obesity, calf tightness, and endurance activities such as dancing, running, other types of endurance training. Another common issue that I see and deal with is our ankle sprains. Ankle sprains are the most common reason for missed athletic participation across the entire body. Typically, it's an inversion injury, as demonstrated here. And sprains are all on a spectrum, from mild to severe, so no ankle sprain is the same as another. You can find bruising, swelling, and significant pain, often on the lateral side or the outside of the ankle. You may or may not be able to bear weight. With severe sprains, you can feel as though you can't put any weight on it. It can feel really unstable. Symptoms can often mimic an ankle fracture or an ankle break. So when in doubt, my recommendation is always go see a provider to get an x-ray. Other common conditions, tendonitis. You hear that phrase a lot. What is it? It's inflammation of the tendons resulting in pain and swelling and dysfunction. Common locations, the picture on the left is on the outside of your foot. These are your peroneal tendons. These control eversion or bringing your foot out. The opposite of that tendon is the posterior tibialis tendon on the medial or inside of your ankle. It inverts your foot. And a common one is the Achilles tendon, which is in the back of your heel. It's very commonly an overuse condition. It can manifest as activity-related pain, which often improves with rest. It can be associated with swelling over the affected tendon, and underlying there can be some partial tearing of that tendon. Typically, it can respond to anti-inflammatories, but it can linger and last for a long time if not treated appropriately. We'll go over ways to treat these conditions later on in the lecture. Arthritis is also a very common condition that I encounter. Arthritis is cartilage loss over time. It can be traumatic in nature from a previous injury, degenerative, which is wear and tear over time, or infectious or inflammatory, things like gout or rheumatoid arthritis. It can result in pain, swelling, and dysfunction. And it's a very common condition. I tell folks it will happen to all of us eventually if we live long enough. But it doesn't always only have to be related to age. Things like trauma at a young age can result in rapidly accelerating arthritis in different parts of your foot. Common locations are the great toe, which is that picture on the left. You can see that the big toe there's not much space between the two bones, indicating cartilage loss. It can be in the ankle, which is in the middle picture. The bone in the middle and the bone underneath it should have a space between them, which they don't, indicating arthritis. And in the middle of your foot, where the toe bones meet the rest of your feet bones, and that can often result in arthritis there. It's typically painful with activity, something we call startup pain, where the first few steps can be painful and you're limping, and then as you loosen things up, it gets better. And it can last, flares of arthritis can last days to even weeks. Another common condition, fractures. They're, as you might imagine, resulting from trauma, sometimes with even minimal energy. They can involve any bone in the foot and ankle. You can see on the left, though, that's an ankle fracture. The picture on the middle is what's called a fifth metatarsal fracture. You may have heard of Jones fracture before. And you can get calcaneus fractures or heel bone fractures, which is the picture on the right. With fractures, you get severe swelling and bruising. It's very painful, and typically you're unable to put weight on it. But just like most things, it's not a hard and fast rule. Sometimes you're able to bear weight even if you have a fracture. I recommend getting an urgent x-ray because the treatment for fractures are all different depending on the location, the severity, and the bone involved. Treatment for fractures can be operative or non-operative. Many fractures I see are managed non-operatively, meaning the body heals the bone on its own. Another traumatic injury that we see all the time, Achilles ruptures. It comes with sudden dorsiflexion of the ankle, which is bringing the foot up in space. Typically with higher intensity of activity, things like trail running, sports, or technical hiking, what you'll find is swelling along the Achilles tendon. You can look at this picture on the right and see the left ankle is significantly swollen. The right, you can see the contour of the Achilles tendon. You can often feel a palpable defect in the tendon. If you run your hand along the tendon and your finger falls into a little valley, that's the defect where the Achilles tendon is ruptured. What's interesting with Achilles ruptures is you're often able to bear weight, and often it's not painful. So just because you don't have pain does not mean you manage to escape an Achilles rupture. The pain often is from the initial injury, but once the tendon is separated, it's often not painful. Another relatively common condition I see, non-traumatic, is a Morton's neuroma. A Morton's neuroma is a disorder of the nerves in your toes, and it can feel like pain, numbness, or tingling that radiates into the toes. It's most commonly located between the third and fourth toes, or what we call the third web space, sometimes between the second and third. It's associated with clicking, and risk factors are narrow shoes. What a neuroma is just a benign growth and irritation of the nerves that run in between the toes, and they can result in the symptoms I just described. A very common condition I see are bunions. The technical term is hallux valgus. It's essentially lateral deviation of the big toe with a medial prominence. So the deviation of the toe leads to the what we call the metatarsal head being prominent, which can be caused from narrow shoe wear. Typically, women's fashion is more narrow shoes than male fashion, and as a result, it's more common in women. Genetics also play a big role in the development of bunions, and trauma as well. Sometimes you can traumatically develop a bunion where you tear the ligament on the lateral side of your ankle, the medial side of your ankle, resulting in deviation of the great toe. The most common complaint with bunions is it's painful with narrow shoe wear, where that medial eminence and prominence can rub up against shoes, causing pain. And the pain often improves when being barefoot. As you might imagine, bunions, it's a spectrum of disease. There's a significant range in severity. This picture here is a pretty severe bunion where you see the big toe crossing underneath the second toe, and it can result in things like hammer toes, which is contractures of the lesser toes adjacent to the big toe. What's called a crossover toe is demonstrated here, where the second toe crosses over the big toe. And eventually, if it lasts long enough, you can get severe arthritis of the great toe from a severe bunion. So I went over a breadth of different conditions. I'll talk in general about different non-surgical treatment options for managing these conditions generally. Non-surgical treatment, first line treatment for any condition, the age-old recommendation, rest, ice, compression, elevation. Many conditions are from overuse, and it's important to rest. I tell folks that these overuse type conditions it's your body's way of telling you need to slow down and rest. And it's often difficult to slow down and rest, especially with people in Colorado and the commitments that we all have. But it's important first step in getting these conditions under control. Ice is often more beneficial. It's more beneficial than heat in the acute inflammatory phase. It essentially decreases the inflammatory response locally in that area and can help decrease swelling. Compression, just like ice, can help with the swelling to get rid of some of that inflammatory response there and flush some of that fluid out. And elevation. Elevation will help with the swelling, which in turn will help with the pain. It's key when you're elevating to have your foot, your ankle above the level of your heart, as demonstrated here. And that's just using the power of gravity to help flush some of that fluid out of the lower extremity. Anti-inflammatories are also critical for pain relief and swelling aid, specifically NSAIDs. You may have heard that term before, but NSAID stands for non-steroidal anti-inflammatory drugs. It's the mainstay of treatment. These are your Advils, your Aleve, or generically ibuprofen, naproxen. Most are oral versions, but oral versions can sometimes cause GI upset, stomach ulcers, increased acidity. Topical versions such as Voltaren gel and the generic diclofenac sodium. These are creams, especially in the foot and ankle. These are the cream and topical options, a great choice because there's not much meat between the skin of the tendon and the skin of the bone in the foot. So I often recommend patients to give this a shot. It's an over-the-counter option. Recommend 2 to 3 weeks of continuous anti-inflammatories for most conditions. We talk about, or people may have heard, long-term anti-inflammatory use like ibuprofen or Aleve can cause other issues. It can cause kidney dysfunction or stomach upset, but 2 to 3 weeks is a relatively short course. So especially in conditions that prevent you from being active, I definitely recommend trying a short course if you can tolerate them. Immobilization is also key. So in a lot of conditions, immobilization is helpful in the initial stage, particularly if symptoms are getting worse. So these are things like a cast, a boot, or a brace. The theory is to stabilize the foot and the ankle to allow for your body's healing response to occur. It can result in stiffness, which is by design, which is why we have folks like Chelsea and Megan to work with you with physical therapy afterwards. But it significantly helps with pain. The type of immobilization depends on the severity of the condition, but in general, we transition from a high level of support and mobilization and generally decrease that support as your symptoms improve. So we often transition from a boot to a brace. We start with the brace if symptoms are not that severe. So now kind of pivoting to operative treatment. So the reason people like me exist as a surgeon is because sometimes non-operative management doesn't work. and we have surgical and operative treatment options to help correct conditions that are resistant to improving non-operatively. So for one example, peroneal tendonitis, these are typically associated with tears or instability, meaning the tendons themselves are popping out of the groove that they normally run in. So on the picture on the left, you can see a clear tear within that tendon, and the solution is, pretty intuitive. We repair that tear using heavy suture to allow for smooth gliding of that tendon and prevent that tear from propagating up or down the ankle. For Achilles tendonitis or Achilles ruptures, there's minimally invasive or open options. Back in the day, and by that I mean 15, 20 years ago, there was no minimally invasive option for Achilles tendon rupture or surgery. So it would involve a large incision with a big scar, which is still done in a lot of places and it has a great outcome, but it carries with it the risk of developing a wound healing complication. So there's minimally invasive options where the incision to repair it is less than an inch, and 2 counter incisions that are also less than an inch to help approximate it. But what that does is allows your soft tissues to not incur the risk of getting an infection while also still maintaining a strong supportive repair. For ankle sprain surgery, it's honestly one of the most common surgeries I do. Not that everyone with an ankle sprain gets a surgery, but more there are a lot of people out there who sprain their ankle, and it's for people that keep spraining their ankle. If you have multiple sprains, you often get to the point where the ligament can't heal, end up getting surgery. So as described here and seen on the right, essentially repair and reconstruct those tendons back down. And what I tell folks is with ankle sprain and ligament reconstruction surgery, I'm essentially retightening your ligaments back down to as though you never sprained your ankle before. So I can't make you invincible, but I can certainly make it as though you never sprained it, and that's the goal of the recovery here. Bunion surgeries, there's over 100 different ways to fix a bunion, and the cool thing is lately, and within the last 10 years, they've come out with minimally invasive bunion surgical options. So that picture on the left, you can clearly see a bunion with the toe deviating off to the side. And that picture directly next to it is the same patient after a bunion correction. With those, we made a bone cut, shifted the bone over, and placed screws across the osteotomy to hold it in place. That same patient is the picture of the patient up to the top right, and you can see it's all done through 4 percutaneous incisions. And that's come a long way, certainly, and something that I like to do in my practice to try to minimize the soft tissue insult with surgery. What studies have shown is that it allows for quicker recovery, less swelling, and less pain after surgery. The pair of pictures on the right is an example of what's called a lapidus bunion correction, which is a surgical correction for more advanced bunions. That can also be done with small incisions. The incision essentially is the size of that plate that I put on there. It's fairly small. But like I said, many different ways to skin a cat here when it comes to bunion surgery. Fracture surgery, similarly, and no one fracture is the same as another. So when you're fixing a fracture, you are essentially a human carpenter. You're putting the puzzle pieces back together, plates and screws to hold things in place and stabilize it. The hardware that gets put in for fracture surgery essentially is just there to stabilize the bone to let your body heal around it. So once you're fully healed, oftentimes we do hardware removals where the hardware comes out, and once the fracture has healed, the hardware is unnecessary because your bone is already healed up around it. So we oftentimes take the hardware out per patient preference, but the hardware is designed to stay in forever. So if you're comfortable and doing well, we don't have to take anything out. For arthritis surgery, there's different options depending on where the arthritis is, but one example is on the left. That's bad ankle arthritis. You can see the whole ankle joint is tilted and shifted, resulting in bone-on-bone opposition. For those and for the right candidate person, we do ankle replacements. It's not as common as hip replacements, knee replacements, so you may not have heard of ankle replacements, but the premise is the same, where we remove the previous joint that has the arthritis, we place an artificial joint in, and what we also do is restore the alignment. You can see before, this patient had a tilted ankle joint that had significant malalignment. We straighten the ankle joint out, which results in better kinematics and better function going forward. The picture on the right is an example of what we do for bad big toe arthritis. So while there are big toe joint replacements, the studies have shown that they aren't very successful. So the reliable, reproducible option here is a big toe fusion for the right patient and the right type of arthritis. So I've gone through a lot and I've gone over a lot of things. I'm going to briefly touch on some preventative care for the foot and ankle. Then I'll turn it over to Chelsea to go over physical therapy and the benefits and different types that exist out there. So in general, for foot and ankle pain, you really want to try to really investigate the shoes that you're wearing. So supportive shoes are going to be good for overall foot and ankle hygiene. In general, the thicker the sole, the more support given. It cushions the foot. And in general, the less flexibility the shoe and the sole, the better. The premise behind that is the shoe doesn't bend and the joints of your foot don't bend. And especially for tendonitis or arthritic conditions in the foot, decreasing the motion across the joint will improve the symptoms and decrease the stress that those joints get. I know there's a lot of talk recently and currently about, lower profile shoes and different types of shoes that allow for muscle strengthening. That's certainly true. If you want to strengthen the muscles of your foot, these kind of lower profile shoes are beneficial, but they don't offer much support. So there are other ways to strengthen the muscles of your foot, but my recommendation is when you're going to be active, especially with endurance activities, you want the support in your foot because you want the shoe to also take some of the load that otherwise your foot itself would take on. Orthotics are great supplements for supportive shoes. So over-the-counter versions work for most people, unless you have a particularly unique foot shape or severe pathology. So in those situations, I suggest we can get you set up with custom orthotics that are molded to your foot. But the majority of patients out there, my suggestion is over the counter. You can usually find something that'll work for you. The goal is to provide cushion and support that supplements the cushion support provided by those supportive shoes. Many different types exist, and my recommendation is to try several different styles. See what feels best. There's living in Colorado, especially in the Boulder area, there's a lot of resources here. A lot of different shoe and running stores that you can go in. You try several orthotics on, see what works well for you, and then you can find a happy medium that'll support your foot the best. Different things such as metatarsal pads can help facilitate and decrease stress on the front of your foot. For example, for Morton's neuroma, that one condition I mentioned earlier, it takes pressure off the front of your foot. I mentioned here correct location is critical because you can sometimes put that pad in the wrong place and it actually exacerbates your symptoms. So if you're considering getting a metatarsal pad because you think you have a condition that could benefit from it, it's not a bad idea to see a provider or someone who specializes in foot and ankle conditions to get a sense of where to put that properly. You can often build those metatarsal pads into your orthotics. So you can see here on this example here, there's that bump that's already built into that orthotic there that simulates what a metatarsal pad would be. Like I mentioned, for Morton's neuroma, another condition is called metatarsalgia, which is increased stress in the front of your foot. These are the conditions that could benefit from metatarsal pad use and orthotic use. Ankle braces, I can relate to patients who don't quite know what type of ankle brace to get because there's a huge variety out there. In general, the premise of the ankle brace is to prevent rotational injury and secondarily stiffen the ankle joint to decrease motion of the ankle that could potentially result in pain. There's a huge variety, like I mentioned, from really, really stiff to really, really flimsy and unsupportive. In general, you want to find something in the middle. Because if it's really stiff, it's going to actually cause more harm than good in some ways, and it could really rub on the side of your ankles and cause you dysfunction and pain. And as you might imagine, really loose ankle sleeves don't provide much support as you're essentially wearing a compression sock at that point. Taping is also not a bad idea. The taping is more of a short-term solution. And what I mean by that is eventually the tape will lose its adhesiveness and it'll start to not work as well. So if you've got the patience and the means to be able to re-tape and tape over again, taping is great and much lower profile than bracing. But these are different examples of things you can certainly do. I'm going to briefly talk about physical therapy, and I'll defer to the experts in a second. But physical therapy is a key part of any rehabilitation, whether you're having surgery or not having surgery. It's great for, like I said, rehabbing. It's also great for preventing injury. So it's a key part of my practice. I work closely with our therapists in our group to either work patients up for surgery, hopefully get patients better after surgery, and do PT for conditions that hopefully we never have to get to surgery for. So it's an incredibly important resource to have, and it's incredibly important to learn good habits, and that's what our therapists will help work you through. Typically, I don't begin with physical therapy right away, because with a lot of conditions, we need to try to decrease the initial inflammatory response and decrease the initial inflammation. Because if you try to start PT right away when everything's flared up, it can actually make things worse. So we typically wait after a period of mobilization to decrease inflammation to resume or begin physical therapy. And good PT hygiene and good habits. Once you have gone through PT and gotten better, it's always good to have some type of home exercise regimen to keep that progress going, to prevent this from happening, or whatever condition you had, keep that from happening again. So one thing I mentioned here, I love to bring this up, and if you're a patient of mine, you've seen me demonstrate this in the room, I'm sure, is this calf stretch. This calf stretching the calves in general, and calf tightness can result in a lot of different conditions that affect the foot and the ankle. So that's it for my portion of the talk. I'm going to pass you guys off to Chelsea, who'll come in and talk more specifics about physical therapy and how they can help foot and ankle conditions. Thank you.
Thank you, Dr. Y. So I'm Chelsea Alexander. I work at Boulder Center for Orthopedics. I am here to talk to you about some of the physical therapy related aspects of each of these topics that he has kind of already talked about. So just brief anatomical overview. Dr. Y already kind of went over this. One of the things that I just like to point out is that there's muscles that are considered intrinsic muscles, so they're found within the foot, and then there's those extrinsic muscles. Those are going to be more like in the calf or in the shin. Those are also going to take a large piece and a big role in what is going on at the foot. All right, so during the discussion today, Megan and I are going to talk about some of the common injuries that we see in the clinic. We're going to try to cover both the non-op and the operative side of things. So if we miss anything, feel free to throw questions in there. So to start with sprains, this would be very commonly a lateral ankle sprain. Oh, I rolled my ankle. That's what you would commonly hear with this. Sprains refer to ligaments, which are that bone-to-bone connection there, okay? So depending on the severity of the injury, when you are seen by a doctor, they will grade it. The grades are 1 through 3. Grade 1s are a little bit on the lighter side, not as severe, maybe a little bit of stretching, not as much tearing, that kind of stuff. These usually recover pretty well within about a 1 to 2 week span. Grade 2 is going to be a little bit more severe. We might have a partial tear. We might have a little bit more stretching, a little bit more laxity or give in the joint at that point. Grade 3s are these near full or complete tears, and these can take up to 3 months to recover from. So this is something important to keep in mind when we are talking to you about what you can and cannot do and in what time frames, because everybody of course wants to get out there tomorrow, but sometimes the severity of the injury itself can limit how quickly we're able to get you back there. So just like Dr. Y talked about, so initially this is going to be that period of protection, maybe some bracing, depending on, again, the severity of it. This part is the try not to aggravate it and make it worse, because you're going to have some inflammation just naturally occurring in the body from the injury itself. That's how our body heals itself. So protecting that, making sure we don't worsen it, kind of giving it the support that it needs to go through that healing experience. After this, or with this phase, we're also going to modify the activities. So if something is, my usual discussion with patients is if something hurts, it's a great idea to not do it yet. So it's good to stay as active as you can, but resting from the activities that are aggravating to you. So again, another phrase that I like to use is an active rest. We want to keep you as mobile as we can and doing things, but we want to make sure that we're not further aggravating this area. During this inflammatory phase, so these early phases, and again, depending on the severity, this might stretch out for a little bit longer. you're going to want to make sure that we're treating some of that swelling. Dr. Y already talked about some ice, compression, kind of that elevation. These are kind of good techniques to be using early after an injury with an ankle sprain to make sure that we're allowing the body to go through the natural healing process, but not allowing it to get too exaggerated. The next part of that, after the inflammatory phase, we're going to want to start restoring some of the natural range of motion that your ankle has. This is most likely going to be limited after a sprain. And this goes for really any sprain in the foot. That's just the most common one, is the ankle. So we'll start returning the ankle back to its range of motion. We want to make sure that we do not force that during this time period, as that can be more detrimental and cause more irritation and could potentially cause an aggravation of that sprain. With this, we'll also want to make sure that we're progressing strength. The other way to think about this is progressing load. So we might start with something that's non-weight bearing, with your foot off the ground, maybe some bands, and then progressing to more advanced, maybe a weight-bearing exercise, then maybe single leg, making sure that we increase the load of that tissue gradually so that it adapts to that new environment as it goes through that healing process. It's important to be loading this tissue at these phases because it also helps with the remodeling and the correct healing of that tissue. Balance is always a main one with really any injury, but especially when we're considering injuries like ankle sprains down at the ankle and foot. It's not uncommon. In fact, I would tell you almost everybody has limitations in balance initially after any kind of trauma, whether it be a sprain or just an easy roll. So restoring your balance is also another thing that's going to be important at that phase, because we don't want you to be at an increased fall risk moving forward. And it's also good for the body to be focusing on that proprioceptive aspect of it, which is your body's ability to know where it is in space, because that will also help with injury prevention in the future. Like Dr. Y talked about, there are some cases that are going to potentially need surgical intervention with this. The cases that I normally see of this are patients that are not really responding to the PT. They continue to have limited activity levels, continuous pain, swelling. They're continuously rolling their ankle. It doesn't have much stability. These are patients that if you're in PT and we're trying the PT thing, I'm going to send you back to the doctor and have you reassess whether we're doing your ankle justice at this point. So if we end up having to get a surgery, you're going to go through a period of immobilization where you're in a cast and then a brace and an ankle boot, and you might have some limited weight bearing during that period. During that time when you're in the boots, there will be some things that we can do and some limitations that we have to be applying to this so that we are protecting that tissue that was just repaired. So with that in mind, we'll do whatever we can to maintain and restore the range of motion again, so that we're trying to establish those more normal movements, again within appropriate time frames as established by the surgeon's protocol. We'll also want to eventually progress into strength. Some of that might be able to be started while you're in the boot, but a lot of this will often happen once you are discharged from the boot and kind of getting more into that weight-bearing phase. And then again, that balance is going to be another piece of that recovery, often applied after you get out of the boot, and we're just kind of trying to restore the foot back to its original status. And then next are strains. So these are different from sprains because they apply to muscles and tendons. So remember, sprains are ligaments, so bone to bone, muscles and tendons. Tendons are the attachment point of the muscles to the bone. Similar grading system. Grade 1 is pretty mild, going to take a little bit less time to recover. Grade 2 is more of a moderate injury, in which you will have more pain, you'll have more swelling, and you might see that decrease in the strength during that. And grade 3 are going to be these more severe, which are commonly known for as that complete rupture of the muscle or of the tendon. This is going to come with usually some pain during, depending on if we're talking tendon or muscle. but then also a lot of swelling, loss of function, and those kind of things. So this picture at the bottom kind of just helps you picture what's going on at the tendon, muscle, and the severities of these different grades. Included in these strains are these Achilles tendon ruptures. So like Dr. Y discussed, some of these will be treated operatively. So he will go in and do what he does to restore the normal tendon connection. And then you will be discharged when cast, boot, phasing, and then at some point you will come to PT. Usually we're seeing patients a couple weeks out of that, again, because we're trying to make sure that tendon and that tissue is protected early on in that phase, and then we'll want to start gently moving that and getting more range of motion restored, more loading and that kind of stuff as you get further out. So usually we're seeing these patients a few weeks out of their surgery. They're usually in a boot or about to transition to a boot with weight bearing. We can do some range of motion with these patients. Obviously, we're going to be careful about stretching the calf too much at this point. Normal protocols usually include a heel lift that occurs or that can be placed in the boot. It's kind of like a high heel, and then you just gradually decrease those over time to allow more stretch on that tendon. That will allow that restoration of range of motion over time, but in a way that will gradually allow that tendon to be able to tolerate that load. PT helps guide you through that, following, again, surgeon orders and the protocols that they have laid out for us. And we will also be working on other range of motion that you might be limited in because you've been in a boot for so long. We might be working on other, some strengthening, maybe throughout the leg, maybe with other muscles in the foot. These kind of things will just kind of piece that together based on what the therapist found in the initial examination during your post-op appointment. Over time, again, as you decrease the heel lifts and then you transition out of the boot, again, it's that progressive loading. We want to start getting you back to your normal function, but we've got to do that gradually so that that tendon can be prepared for the load you're going to put on there. And then Achilles tendon, again, is this common one that we all hear about, especially with some of the football players right now. Other ones that can also occur are peroneal tendon. So that's going to be often found with a lateral ankle sprain or an ankle roll, is those tendons on that outside get strained with that mechanism of the foot coming in and that kind of the weight going onto the outside. That strain is going to follow similar principles as to the Achilles and other tendons, and will follow similar progression after surgery if that is required. All right, fractures are next. So with fractures, like Dr. Y said, not all of them require surgical intervention. Some of them will go through a period of immobility, either with a boot, most often a boot, maybe a shoe, but maybe a cast. And then after that period of time, once you are starting to be allowed to move the foot again, we want to be restoring that range of motion. Oftentimes, just being in a boot causes limitations in range of motion, weakness, and obviously limited balance. So these are things that we're going to be trying to restore at a progressive rate during the therapy after either the surgery or after a non-op fracture. Activity modifications, if you have a fracture that they do treat non-operatively, obviously you're not just going to get back in there. We want to make sure that we give it that period of rest. Other aspects that we will focus on in the PT after this is once you get out of that boot, oftentimes the walking, how you're moving, those gait mechanics, those are going to be really altered because you've been in a boot, you're very stiff, you're still gaining your strength back, and then you have this injury that your body was recovering from. So oftentimes during PT, we have to work on reestablishing that normal movement pattern for walking. So that'll be also something that your PT will help guide through if you have to go through this. Another aspect of fractures is stress fractures. So this is often from repetitive loading, overuse, injuries, these kind of things that'll show up as that stress fracture. And Dr. Y can diagnose that for you. And then he'll send you to PT after a period of activity modification, right? We don't want to be stressing that fracture. We don't want to be causing more strain to that bone at that time. So we want to be modifying the activities to make sure that we are loading that properly as you get released progressively. Also treating any impairments that might have led to this. Do we have a weakness somewhere? Do we have a limited motion that is causing more stress on this area? Is it overtraining? Can there be a patient educational piece of this that we can kind of patch together to make sure that we're treating the entire condition? And then again, a period of gradual reloading where we start with lighter exercise, lighter loading, and then progressing that back to the activities that you want to get back to doing. Also, Dr. Y mentioned hardware removal is a common aspect of this. With PT, you may or may not need that after a hardware removal. Usually it's pretty low stress. It's usually not very, it's really not too much PT after the hardware removal. It's a period of inactivity, maybe restoration of impairments. Usually not too invasive with the PT with that piece of it. And then another topic for us is the arthritis that Dr. Y talked about that can happen at a couple different locations in the ankle and foot area. So the ankle itself, which you can see by this picture, and what kind of occurs during the arthritis. So arthritis is inflammation of the joint that occurs, and that it can cause degradation of the different cartilage aspects and the different pieces of the joint. With that, it's often associated with a lot of pain, stiffness, and swelling, and can be episodic in nature, meaning you may go through a period where it's really aggravated, and then it'll calm down and be fine for a while. So when these episodes occur, the idea with the PT is the modification of activity so that we're not further aggravating, and we'll want to make sure that there's not areas of stiffness, limited motion, or a decrease in strength that can be attributing to increased stress on the joint. What I usually tell patients is, I'm not going to fix the arthritis. I can't change that. That's happening. But what we can do is we can influence everything around it so that we can better support that joint as it's kind of going through this inflammatory phase. With this, you might also need to consider bracing just to kind of support the joint with this. It might be compression. It might be one of those sleeves that just kind of helps with giving it a little bit of light support, helping with the swelling at this point. Shoe wear is also important with this to help support as best as we can. One of the conversations I usually have is when patients have that big toe arthritis kind of at that MTP joint, so that where the toe meets the foot. Often with that, a stiffer soled shoe can be helpful so that you're not being required to bend the toe as much. And that can reduce the amount of stress through that joint and allow you to be a little bit more active. The other thing to always consider with arthritis is weight management. We want to make sure that we're not adding increased load on the joints. So making sure we're able to stay active and managing the weight with that process can often be a hard balance to find when we're dealing with pain with movements. So it is something to just be considering that can be a factor. And then I'm going to hand it over to Megan for a couple more topics.
Okay, fabulous. I'm Megan Doyle. I'm another PT over at BCO. And the next topic I'm going to be talking about is tendinopathy. So this is to not be confused with tendonitis or like a tendon strain that we talked about a little bit earlier in the presentation. A tendinopathy is when a tendonitis becomes more chronic. So you couldn't get it to calm down in that initial stage, and there is like literal collagen changes in the tendon itself. So these areas include the same thing: the Achilles, the posterior tibialis, the peroneal tendon. So acutely, when it's tendonitis, we work on ice. When it's acute, we work on rest and isometrics. And then as we grow and it becomes less severe, we work on reloading it in the remodeling stage of it. So we try to just help you gradually return back to activities, maybe start with like closed kinetic chain activities, like some simple heel raises and squatting. And then as things start to feel better, we'll progress to those more plyometric activities like jumping and returning to sport. One thing to keep in mind with a tendinopathy over tendonitis is that in PT, we do use a rule of like, if there's pain that's less than a 3 out of 10, the activity is okay to do as long as it calms down by the next day. And then if it's too much, it was too much activity, and we kind of go from there. Tendinopathies can be a little frustrating when it comes to reloading them. Some days it will be a 3 out of 10, other days it'll be a 5 out of 10, and we just kind of gauge it day to day. Okay, our next topic that Dr. Y spoke in depth about is bunions. So these are fun, I personally think, to work on. They're a protrusion or a bump on the outside of the big toe. Like Dr. Y said earlier, the contributing causes are narrow shoes, time on feet, and foot mechanics. So we can change the type of footwear that we wear, which will be very helpful. Time on feet, it's kind of hard depending on your occupation or what you do for fun. And foot mechanics, we can totally change in PT. Again, we can't physically change how the joint is aligned. Dr. Y will do that in the surgery. But we can change how the foot and ankle are moving based on what we do in your evaluation and how we see how you move. So other treatment is going to be spacers or taping. I always tell people to get those yoga toes online. They're like $10 and they do a good job of splaying out your feet, and you can wear them after a long day at work. It's not really realistic to wear them in your shoes, but they're a nice rest at the end of the day. Another thing that we do, skipped over a couple slides. Another thing that we do is work on strengthening your foot intrinsics. So when Chelsea briefly talked about the anatomy of the foot, you can see on the bottom of your foot, there's a bunch of muscles that line like the base of the toes, and they control this motion and then the together motion. So we can work on different activities to get the toes to actually do that, and that's going to contribute to more mobility and better motor control to hopefully get your bunion in a slightly better place. Okay, next topic is plantar fasciitis. So there's pain in the morning or after sitting for a while. I tell people a good way to manage this if the pain in the morning is the most problemsome is a lot of people will sleep with the comforter over their foot, so their foot's in a prolonged position like this. So if you just pull the comforter from over that, it's a little bit less of a stretch, and if your foot gets cold, put a sock on it. Or first thing in the morning, try to get your foot over the side of the bed and do some ankle pumps before you take your steps so it's not as shocking. Risk factors include high arch and changes in activity levels. And other things that we can do for treatment, other than the symptom modifications that I talked about, are stretching, shoe wear, and same thing, strengthening those foot intrinsics. The foot's kind of easy because you just work on strengthening your foot intrinsics and a bunch of other mobility things. And we can talk about that more specifically if we actually get to formally evaluate you in physical therapy. Okay, next we have a Morton's neuroma. Sorry, I keep skipping over stuff. And that's the tingling and burning pain that Dr. Y talked about a little bit earlier in the front of the foot. Feels like a stone is there, and it's just not very fabulous to feel. The most common time I hear about this is like when people went on like a really long hike or a backpacking trip and their foot swells up inside of their shoe and they're not able to change their shoe while they're out, and they're like, I feel all this tingling inside of it. So first I tell them to have symptom relief by icing it, getting those toe spacers in on those toes again, and just kind of rolling out the middle part of the foot with like a tennis ball or a lacrosse ball, and that can kind of get it to relieve. But the other things that you need to consider are putting in the metatarsal pad like Dr. Y mentioned, and you need to do that appropriately because if you put it on the wrong place, there's going to be too much pressure. And then the other thing that we can do long term is improving the foot mechanics again. Okay, so conservative treatment as a whole. The main things that we're going to focus on are mobility, strength, and balance in the physical therapy world. Everyone is different when it comes to their mobility, so after we evaluate you, we work on usually a couple things at a time. I don't like to throw 500 things at you at once. I look at your biggest deficits in terms of your strength, and we work on those in a pain-free range. And then balance is always the answer for the ankle. And then other things that we're also going to look at are what are happening at your knee and what's also happening at your hip. That's very complicated, and we don't have to get into super detail about that unless you have questions about it. But a lot of things from up the chain, like at the hip and at the knee, will contribute to how your ankle and your foot are moving. Shoe wear, we've already talked about quite a bit. My other advice for shoe wear is that a lot of the running stores around here are very fabulous, and they have force plates and this program where you walk on the force plate and then it shows you how your foot is moving and the ground contact, and then they are able to like put that into a program, and then they can tell you what shoes and what orthotics work best for you, so you don't have to try on like 500 pairs of shoes, you just try on 5. Other things that we talked about were braces, orthotics, and spacers. Those are pretty general. If you guys have specific questions on them, we can talk about that. And then we always work on modifying activities. I myself am a very active person. I'm sure most people listening to this talk is a very active person. And when you're injured, it sucks to not be able to move. So it's our job to get you back to that movement in a safe and pain-free way, and working with you to modify those activities so you can at least do something in the meantime while you wait for all that to heal. And that's it. Any questions?
Thank you very, very much. We're going to get the doctor back up there now and take some questions from the audience. We already have quite a few questions, but we want to remind the audience that now is the time for questions. And you can put your general question in the chat below the video on your screen, and we'll get to as many as we can tonight. And these are going to be in no particular order. And if the PTs are going to answer some of these, they'll step up there. So you may see some movement tonight, audience, on whoever is going to answer the question and elaborate on that tonight. So can you touch on cuboid syndrome? This person said they believe they currently have this. They have a bump on the outside of their foot and it's painful.
So something like cuboid syndrome is pretty uncommon, and it's one of those things that can often be a diagnosis of exclusion, meaning we want to make sure that there aren't other things that can mimic that specific syndrome before diagnosing it. Bumps on the outside of the foot could be a few different things. It can be a bony mass, meaning depending on the shape of your foot, if you're particularly thin, you may notice these extra bumps or larger bumps on the outside of your foot. And while they could just be a normal anatomic variant, they could just be more prominent on you. They could also be other things like cysts or small soft tissue masses that become firm. So it's difficult, especially without an evaluation, to give you a formal diagnosis, but definitely something that if you find that it isn't getting better and causing you dysfunction, I'd recommend coming in to talk about it.
For the last several months, this person has had intermittent pain on the outside of their right heel. It almost feels like their heel is dry, but it's not. Do you have any idea what might be causing that?
You know, again, it is difficult to really give you a diagnosis without being able to lay eyes on you and do an exam. But there are other sources of heel pain that are often not plantar fasciitis. You know, there's different things like something called fat pad atrophy, where the cushion of your heel, the fat itself, can atrophy and you lose that support. There are also other nerve conditions, branches of the plantar nerve that are in and around the heel that can get impinged and potentially irritated. You know, without being able to really do a formal exam, it's going to be challenging for me to give you a diagnosis, but I can tell you that there are a few other things besides plantar fasciitis that it could be, and again, I'd suggest coming in for an evaluation to really be able to rule it out.
All right. And we do want to remind our audience that you can schedule appointments and get your specific questions answered by the doctors and the PTs. Is treatment of Taylor's bunion the same as the big toe bunion?
So, good question. A Taylor's bunion or a bunionette is deviation of the small toe towards the big toe. When a bunion is a big toe going towards a little toe, the Taylor's bunion is the opposite. Treatments, at least the conservative treatments, are largely the same, meaning wider shoes, working on improving your foot intrinsics and just taking pressure off of that prominence on the outside of your foot. Operative treatments are also fairly similar, meaning it involves changing the bony anatomy of your toe to take the pressure off of that area. So while it's on a different part of your foot, the basic kind of understanding and treatment options are very similar. Yeah.
What dosage do you recommend for NSAIDs, oral, and Voltaren?
So that's a great question. So when it comes to things like Advil or ibuprofen, a moderate dose somewhere in the range of 400 milligrams every 6 hours is a reasonable amount. You can take up to 800 milligrams every 6 hours in a given day, and potentially more depending on the condition. But my suggestion is to not overload that ibuprofen right away. 400 milligrams every 6 hours is relatively safe. When it comes to Voltaren gel, you can apply, a dollop or, a small amount of that over the area. Rub it 3 to 4 times a day is relatively safe to do.
Okay. This person has neuropathy in their feet. It aches when they're on their feet, especially for long periods of time, also when they're walking longer distances. How can they get relief for this to regain mobility?
Neuropathy is a tough problem to solve. And what it is just like ligaments, tendons, joints can wear out over time, nerves can also wear out over time. The most common cause of neuropathy is often diabetes, but it can be spine pathology and sometimes related to medication use, or unfortunately just idiopathic, which means without a great cause. So it is the nerves themselves as they wear out at the tips of the toes. The toes are the furthest thing from the brain. That's the furthest your nerves go. They can cause numbness, tingling, and even pain in the toes and going up your foot. There's no great way to solve the problem, unfortunately. There are medications that exist to try to decrease the symptoms of the nerve pain. But unfortunately, there's no way to regrow the nerves or to heal the nerves directly. So when a patient comes with neuropathy, it ends up being a discussion of managing the symptoms, less so reversing the pathology.
This person has had a bunion 6 to 9 months ago. They don't have pain anymore, but when they walk, like on the ball of their foot, it feels like they're walking on a walnut. They don't have a growth that shows on the MRI. Any suggestions for what to do with this?
So it could be a few different things. Some of the things we mentioned in this talk, something like a neuroma or what's called metatarsalgia, where you have increased stress on the bottom of your foot. But without an obvious growth or a bony mass on the bottom of your foot, it may just be a function of the tightness of your calf muscle putting increased pressure on the bottom of your foot. If you imagine this is your foot, if you have a tight calf, it's hard to bring your foot up and stretch against a tight calf. So your foot is pointed down relative to an average tightness of the calf. So the ball of your foot, the forefoot, gets extra pressure, something we call forefoot overload. And my initial suggestion for most folks is if you can, stretch your calves daily, regularly. And if you find that that is not enough to alleviate those symptoms, then certainly come in for a formal evaluation.
Another question, a little bit specific, but let's get through this. On their left foot, their big toe locks up. It's numb.
Stat team, room 213. Stat team, room 213.
Let me repeat that, please. Their left foot, the big toe locks up and it causes numbness and coldness. Is that treatable?
It could be. It depends on what it is. And there's a chance this could be something related to arthritis of the big toe. This also could be a nerve condition. So without proper imaging and a formal evaluation within a physical exam, it's going to be difficult for me to tell you exactly what it is. But again, my suggestion is if you're concerned, come on in for an evaluation. We can get x-rays and then go from there.
Is wearing a boot to immobilize the foot and ankle still an option?
Stat team, room 213. Stat team, room 213.
Especially if it's long-term.
Could you repeat the first part of that question?
Is wearing a boot to immobilize the foot and ankle still an option, especially if you're doing it for the long term?
So I would say for the short to medium term, it's a great option. Long term can certainly cause downstream effects. It will cause some more permanent or long-term stiffness of the ankle and joints of the foot. It can also weaken a lot of the muscles in the foot and ankle as you no longer have to rely on them. You instead rely on the boot. The height of the boot can also throw off your pelvic balance, and you end up with a functional limb length difference because the boot on one end is taller, and that can throw other parts of your body off too. So I try not to keep patients in a boot longer than 6 weeks for that reason, because it can cause other issues. So I would suggest avoiding any long-term use of a walking boot.
During the presentation, there was mention of non-invasive treatment options for bunions, such as toe spacers, maybe PT. Do you have any other recommendations?
So when it comes to non-operative treatment for bunions, I think toe spacers are great. Wider toe shoes are great. PT is also an option too. I would say, and I can also let Chelsea and Megan talk on this, but I think physical therapy works well for the milder bunions because your goal is to strengthen the intrinsics to help prevent it from worsening. Unfortunately, when you get to the more severe and advanced bunions, in some ways the damage is already done, and it's hard to undo years of progression of the great toe over, and you get these, for lack of a better term, muscle memory, where your soft tissues are going to recoil to that position no matter what you try to do. But if you are proactive and notice the development of a bunion early on, then PT absolutely, strengthening the intrinsics can help prevent the progression going forward. Yeah, of course.
So also for the more mild bunions, I mentioned the toe spacers and the wider footwear. They sell these like little individual toe spacers that just go between the great toe and the second toe. And they're pretty like malleable. They're usually made out of silicone. So if it's pretty comfortable in your shoe, you can wear that for a while. I actually wear one myself on my right side to try to correct mine. And then in PT, part of the problem with the bunion is how poor the push off is coming from the first toe. So your primary like loading bones through your foot are your first toe and your second toe, and it will deviate off to the side a lot when you start to develop that bunion. So we'll work on like trying to stretch that and correct it a little bit. We can't again change how the joint is forming, but we can kind of work towards correcting the mechanics a little bit more. Oh, okay.
Also a follow-up to that.
Okay.
Can your body alignment, like from your hip down, help with aligning the bunion so that it won't be a bunion anymore?
I wouldn't necessarily say the bunion, but it could help with like your overall ankle mobility. Like if you're overcompensating into like pronation or supination, if you're having a torsion from your femur coming from your hip or your knee is collapsing downwards, that can help to correct some of the stuff going on at the ankle joint itself. But I don't think that'd be really helpful for a bunion.
Okay, thank you. Can you please speak about corns and calluses? This person is having trouble doing anything about that. They do use custom orthotics, but nothing seems to work.
So recalcitrant or corns and calluses that don't go away. that usually is a sign of an underlying bony prominence of some sort. So you may have a benign growth of the bone, or you may have an alteration of your foot mechanics where you are putting increased pressure over that specific area because of the underlying bone, either from sometimes it's arch collapse, sometimes it's from loss of ligamentous support of the foot. So it usually indicates some type of underlying bony prominence. So if you tried all the things to have it go away, the next step is getting an x-ray to take a look at the bones of your foot and seeing what is directly underneath there, and potentially that can be addressed depending on what it is.
Okay. Do you treat people with erythromelalgia?
Could you
Does that sound right?
Is it arthro?
Erythromelalgia.
Erythromyalgia. To be honest, I'm not super familiar with that condition, so I can't say that I have treated patients with that before.
Okay. You guys spoke to this in the presentation, but can you repeat again how the hammer toe is corrected?
So hammer toes are essentially what we call extension contractures of the little toe. So if these are my toes, the little toes begin to curl in this fashion here, and that's usually from the extensor tendons that run on the top of the foot. It can often be from a bunion, meaning the great toe deviates over in order for it to make room. The lesser toe has to curl in shoes to accommodate it. But it doesn't always have to be related to bunions. It can be from other types of foot tightness and intrinsic muscle tightness, causing the tendons from outside the ankle to have to fight harder to bring the toes up. If you start to notice that you're developing a hammer toe and it's relatively early on, things like gentle stretching of the toes themselves, meaning if your toe is still what we call passively correctable, meaning you can straighten the toe out, you can take your toes and straighten them out and in fact bend them down to try to stretch those tendons. But oftentimes, patients who I see in clinic, the damage is already done, so to speak, meaning they're more rigid and fixed, and it's hard to undo years of contracture with weeks of stretching. This is something that if you start to notice it, early intervention is always beneficial here.
Okay. Back to bunions again. Do you have success with retraining great toe abduction muscles to prevent bunions?
That's a question for our physical therapy folks.
I would say that that's not something we find to be hugely beneficial. I think training the intrinsics in general gets as much support as you can from those tiny muscles supporting the foot. Oftentimes I don't really fully train that. So I would say probably not hugely beneficial.
Yeah, and I can speak to that a little bit. It's difficult to isolate that muscle and difficult to train it. And it is, again, if you're going to get success from it, when the bunion is milder, that's when you're going to get the most benefit out of it to, as they spoke about, kind of better training your gait pattern. But once you get to the more moderate and advanced bunions, there are too many soft tissues that get contracted and stuck in that position. It's going to be really hard to overcome that.
Do you treat a bunionette, which is the bunion on the little toe, the same as the bunion on the big toe?
Yeah, that was a question from before, the Taylor's bunion. So same premise where you can support the shoe, wider shoes, and the surgical treatments are often similar.
Okay, thank you for that. This person did get custom orthotics. Feels pretty good even after walking a long time, but then at the end of the day, it doesn't feel very good.
That's also something difficult to really pin down My sense is that it's not necessarily related to the orthotic itself, it's an underlying foot condition. Potentially arthritis, tendonitis, foot mechanics alterations. But again, we'll need to investigate that more with a formal evaluation before I can tell you exactly what that is.
Okay, perfect.
Megan has something to add.
The one other thing I'll say when people get orthotics is they're obviously made for you, so they're correct, but people go from wearing a shoe without them to a shoe with them completely full time. So I usually tell people to ease into the orthotic and track your steps or track your time on your feet if you're going for like a 20-minute walk, wear the orthotic then, take a break from it, walk around the house and then put it back on later in the day. Don't go 0 to 100 from no orthotic to orthotic. That could help.
Thank you. What's the difference between a podiatrist and an orthopedic MD, specially in foot and ankle? Both do surgery. Is there a philosophical difference in treatment?
That's a great question. So the primary difference is the difference in training. So podiatrists go to podiatric school, they don't go to medical school. They go to, just like orthopedic surgeons, they go through a residency, but the focus on the training of the residency is just foot and ankle surgery. So what I tell patients who ask questions like this is, with orthopedic surgeons, we are trained in the entire musculoskeletal system, and through our training have done surgeries all over the body. And there are certain relationships with the rest of your body that can come into play when it comes to treating the foot and ankle. So while surgeries are roughly the same, with some subtle differences, there are some schools of thought between orthopedic foot and ankle surgeons and podiatrists that can differ. So while there are great podiatrists in the community here and across the country who do great work, there are some differences that in some conditions that may be better off treated with an orthopedic surgeon. But podiatrists in general play a great role in serving our community. I think they also do a great job of treating the foot and ankle.
Okay. Is there a time to use one over the other?
So I would say for more complex conditions, I think the orthopedic surgeon may be of benefit to you, only because the more complex the condition, it's going to have other effects to the rest of the musculoskeletal system. So there may be some involvement elsewhere or contribution of that condition to some other issue elsewhere in the musculoskeletal system that needs to be taken into account, which may be better treated with an orthopedic surgeon.
Okay. Thank you for that clarification. In addition to shoes with a wide-toed bed and insides, how can this person relieve gout pain? They have to be on their feet a lot.
So with gout, there's two kinds of ways to manage it, meaning there's an acute flare of gout when the symptoms are the worst, where the joint is swollen, it's inflamed, it can be red and warm to touch. That is treated with an aggressive course of anti-inflammatories. You can be ibuprofen, but typically there's a medication called indomethacin, which is prescribed for a 7 to 10 to maybe 14-day course to get the acute phase to calm down. If it truly is gout, then there are long-term medications to help prevent gout flares. So without going into too much detail, if you are having pain related to gout and good supportive shoes and NSAIDs are insufficient, then you should investigate potentially talking to your primary care doctor about starting a long-term anti-gout medication. Or if you are taking it, maybe adjusting or altering the medication, because if you're continuing to have pain from gout or gout flares, that may need to be adjusted. With the side note being, if you have enough flares of gout, then you can develop permanent arthritis in those joints, because the inflammation from the gout flare will eat away the cartilage. So if you have enough flares, then you could just now be dealing with essentially arthritic pain. So what we discussed before, the different ways to manage arthritis, but if you are unable to manage it that way, then it may be time to see someone or see a surgeon for a discussion of a possible surgical intervention.
For chronic plantar fasciitis, can you discuss percutaneous tenotomy, PRP, shock ultrasound, et cetera, treatments?
Yeah, so those treatments are for patients who are unable to get relief with non-operative management. So the PRP injections or platelet-rich plasma injections, ultrasound, shockwave, those are also in the non-operative realm. Things like percutaneous tenotomy are as a surgical intervention. So what I'll tell you is that there's some data out there to suggest things like shockwave, ultrasound, and PRP injections can be beneficial. But the data isn't as strong as what like physical therapy, for example. Meaning PT has been shown to at least more reliably improve patient outcomes with plantar fasciitis. But that doesn't mean to say that those aren't options for you. I would say we should reserve those options after things like PT have failed. Percutaneous tenotomy is essentially just cutting the plantar fascia and releasing it, which is one of the successful surgical outcomes. But like I said, I would only reserve those for folks who have failed long-term PT. And by long-term, I mean at least 4 to 6 months of PT, because it can take a long time to get over.
Okay. Thanks for discussing that. Is there such a thing as an orthotic that's molded to support just the forefoot?
I've seen plenty of orthotics that support the heel and the midfoot and stop at the forefoot. I don't know of orthotics that just do the forefoot and not the rest of the foot. I don't know if you guys have heard of that as well.
I have not. I think you can get a custom one.
Okay.
But you have to go to like a P&O guy.
Yeah, Megan's saying there may exist a custom, specially made one for you, but you'd have to go to an orthotist who specializes in forming these. But it's pretty uncommon, frankly. It's pretty rare. I haven't come across that.
Okay, thank you. Do you think the bone stem machines work?
So bone stimulators, they are used for bones that haven't healed. So whether it's fractures that haven't healed or fusions that people try to fuse bones together didn't heal. So they can work. And the premise behind them is if, usually 6 months have passed from attempted healing after surgery or non-surgery, these are devices you put over the skin, over that area to send pulses to the bone to try to jar it to get to bleed a little bit, essentially trying to get it to heal. So these can work, and there are some studies to show that they can work. But I like to say it's a case-by-case basis when I decide to use it or not. So for example, if someone's had a surgery and there's x-rays showing that, let's say, the hardware supporting that area has failed, no amount of bone stim is going to help that area heal. The hardware needs to be revised. But alternatively, if you've had a non-operative management of a fracture, it didn't heal, bone stim is a reasonable option to try to get it to heal before going into a surgery. So it's a case-by-case situation.
Okay. Could you comment on plantar plate ligament ruptures?
So plantar plate ruptures, plantar plates you can consider like a hammock that is underneath the joints of the toes. So where your toe meets your foot, we call the MTP joint. There's a hammock underneath them that supports that joint. That plantar plate can tear, and you may have heard in sports a turf toe. A turf toe is a type of plantar plate tear of the big toe. So it's more common to get these plantar plate tears from a degenerative nature, meaning wear and tear over time. Eventually that hammock loosens and atrophies, and you get what leads to metatarsalgia, where the front of your foot, the ball of your foot, gets increased pressure. Uncommonly, it can be from athletic participation, like an acute injury such as turf toe can cause it. But more commonly it's degenerative. And for most degenerative conditions, once they're diagnosed, we don't jump to a surgery. We try to manage it with shear modification, physical therapy, that type of thing. But if it is an acute injury, depending on the person, the athlete, and the injury, we sometimes intervene acutely with surgery.
Can red light therapy help Sludge.
Tarsalgia.
Help me out there.
So it could. It's one of those interventions that's not as well studied. So it is. What I tell folks is it certainly can't help or hurt. Sorry, can't hurt. Excuse me, can't hurt. So if you have the means, the patience, the time to do things like that, I suggest exhaust all your avenues before considering a surgery. But the data out there isn't as strong for that specific condition. So I don't recommend it to folks, but if they're interested, I tell them, I don't tell them to stop.
If you need knee and ankle replacement, which is best to do first?
It's a good question. I do get that question from time to time. My suggestion is to address the knee replacement first. Now, if you have knee arthritis, that's not nearly as bad as ankle arthritis, meaning the ankle arthritis is really limiting for you, then I would do the ankle arthritis first. But if they're both roughly the same in terms of severity and pain, if you address the knee first, the reason that's beneficial is by realigning your knee above your ankle. When I do my ankle replacements, I align that ankle replacement to your joint above, which is your knee. So if we restore the mechanical axis of your knee, your ankle replacement will match that mechanical axis as well. But again, if you've got terrible debilitating ankle arthritis, you won't be able to recover from a knee replacement well if your ankle is hurting you.
Okay. Can you discuss more on plantar fasciitis healing therapies?
All the interventions we discussed are essentially trying to get that plantar fascia to heal. So it is, again, correct me if I'm misunderstanding the question, but it's the different types of initially rest, immobilization, anti-inflammatories, then physical therapy, trying to stretch the calf, stretch the plantar fascia. That's all in efforts to get the plantar fascia to heal and essentially decrease the stretch on it. It's usually the tension on that plantar fascia and the calf muscle that causes it to get inflamed. So all those interventions are trying to get it to heal.
Okay. Will low-dose radiation help ankles with bone-on-bone arthritis?
No. So low-dose radiation typically is used to prevent formation of extra bone. So what's called heterotopic ossification. So bone-on-bone arthritis is not because of extra bone growth. It is because the cartilage capping those bones has worn away, resulting in those bones rubbing against each other. So I don't know of any data to suggest that would help, and frankly, intuitively, it doesn't register or make sense to me that would cause any relief or improvement of symptoms.
Are you familiar with the studies from a California university that show cartilage growing back in mice? Have they started with humans?
So while I don't know of that study particularly, but they have been for many years trying to grow cartilage in some capacity, across the board. The issue with cartilage restoration is that it works the best, or has been shown to work, in small areas, so focal cartilage loss. So we're talking about, the way I describe it to folks is, if you're driving in the street, there's a pothole in the street. That's a small focal area that we have current techniques to regrow it. And that can be done in the knee, the ankle, all over the body. The issue with arthritis, and this is usually in the context of, I get this question, is the arthritis, the cartilage loss is diffuse. And once you have diffuse cartilage loss, meaning you don't have a focal area to fill in that's surrounded by healthy cartilage, it becomes incredibly difficult to regrow. And the studies have shown that it's not sustainable or feasible. If someone could show that in humans, they would revolutionize medicine, frankly. The hip and knee replacements would be extinct. So, and clearly that's not the case. So it is something that potentially, hopefully, is on the horizon, but it's definitely not in the near future.
What are your thoughts about nightly toe and lower leg cramps?
Cramping, unfortunately, is very nonspecific, meaning there are a lot of different things it could be. So without appropriate context and medical history, it's going to be really difficult to give you a straight answer as to what's causing the cramping.
Okay. Are the physical therapy sessions supervised by a DPT, or is a program planned by the DPT after the first evaluation and implemented by a PTA, a PT assistant?
That will vary depending on the clinic that you go to. So a physical therapist, whether it's someone with a DPT or a MPT, is who performs the initial evaluation. That plan of care that they develop at that point can then be executed by the PT themselves or support. That could be any kind of support staff that would be trainers, it could be PTAs. So the execution of that plan of care can be performed by physical therapy assistants. That will also depend on your insurance. There are some discrepancies with different types of insurance. But bottom line is no, just because the DPT or MPT does the evaluation does not mean that they are the only person that you will see in most clinics. But the PTA or trainer or whoever support staff is helping support that care should be following that and checking in with that PT.
Thank you. This person had bunion surgery already, but it's coming back. Can they have surgery again?
So short answer is yes. There are various different ways to revise or treat a bunion recurrence. There's no straight answer I can give you about how that's done now, because it all depends on how it was initially fixed, what the x-rays look like, and the potential condition. But yes, recurrence of bunion is not uncommon, and it certainly can be addressed.
What do you think about the long-term wearing of orthotics? They're talking about decades, 30 years.
So what I'll tell you is I have many patients who, religiously wear orthotics and stand by them. I am of the opinion that every so often they should be altered, adjusted, reevaluated, only because our foot shape changes as we age, over activity, over time, and the orthotics themselves can often wear out. So, what interval is that? Somewhere in the 5 to 7 years-ish is not a bad interval to have your orthotics at least looked at and evaluated to see if something needs to be altered. But I'm not against wearing it over that extended period of time, as long as you are making sure that they are not wearing out and that your foot shape hasn't changed.
Okay. How do you treat capsulitis?
So capsulitis is a non-specific term about or describing inflammation of the joint capsule. So that can be any joint. That could be the shoulder, the ankle, the hip, the knee. In general, it is an inflammatory condition, and depending on the joint initially, the recommendation for treatment would be similar to what we described for other treatments. Immobilization, rest, anti-inflammatories, followed by physical therapy type exercises to restore motion to that joint in a progressive manner. Specifics will depend on the joint. So depending on what joint you're describing, then there's other ways to go down that path. But in general, it's more or less similar to what we described in terms of how to manage it.
Okay. We still have quite a few questions, but we're almost at the end of our time here. So we're going to take a couple more and then wrap this up tonight. We do want to remind our audience that if they would like to get questions to you, they can email pr@bch.org, and that's where you can send additional questions or unanswered questions to. This person has been using whitey patches for general foot plantar fasciitis heel pain for many years. It's been pretty effective. But now they're getting older, they're getting arthritis. So running is getting to be a little bit of a challenge. Do you know if those patches are making things worse?
I don't think they're making things worse. I think it's more a case of as we age and continue our activity, things just wear out. And that includes our joints, our tendons, our ligaments. So the same interventions we were doing before don't provide as much relief. So it's more the condition worsening, not necessarily that that specific patch is making things worse. So that's not an uncommon thing that I hear in patients.
How do tight calves affect the feet?
That's a big topic to untangle, but without getting into too much, the calf or the Achilles works with the plantar fascia and other ligaments and muscles in our foot to allow for gait. And the different phases of gait, the calf is involved in some capacity. So tightness of that calf can result in compensation of the other tendons and muscles in your foot. That can result in other foot and ankle pathology. So in fact, you can make a whole lecture specifically on that topic. So I'll leave it as general as that.
Just to follow up to that, are support stockings at the end of the day worth wearing to ease calf tiredness?
So support stockings are good for swelling, and that can be from a lot of different conditions. So in general, it's a good idea. Calf tightness is going to be best addressed with stretching before activity, during the day, afterwards as well. So the stocking is a good idea, but not specifically for the tightness.
Okay. We have come to the end of our time tonight. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us and have a good night.